So dynamic method of doing the stability, that is your stressing this pelvis under your, stressing it under your GA and see how much it is going, right? Right? Yes or no? That is also, that is a telescopic. This shows this instability of this there where you need to go for surgery. But under GA manipulations is nowadays a matter of a bit controversy. But telescopic test is always being done, particularly posterior dislocation there. Another point in your displacement instability is that how much the posterior part is involved. How much the posterior part is involved. Acetabulum, out of this, the maximum part of the acetabular fractures are occurring following posterior dislocation of the hip. Maximum number of patients are coming where there is involvement either to the posterior acetabular lip margin or posterior column. These are the burden. This is the burden. Now, in this category of the patients also, one group is stable, another is unstable, particularly where the lip is concerned. If the lip is involvement is less than 20% of this area, probably it is a stable candidate. You know, this posterior lip again been subclassified according to 15 classifications depending upon the size, combinations and involvement. Yes or no? That part is already discussed. But here again, that this how much we can consider to be stability, instability already tested. Indeed, if it is unstable, this is not a candidate for your conservative treatment. You need to go for treatment. 1 point. Number 2, also radiological point of view, if you do a 3D reconstruction and see the posterior lip of the acetabulum, if their involvement is more than 20% of the area, probably it's not a suitable candidate to go for your conservative treatment. Here you need to go for operative treatment. Then again, if the fragment is there in between these two, one fragment supposing lying between the two articular surface, you need necessarily go for your operative treatment to replace it. Remove it, otherwise it is a potential cause of your post-traumatic osteoarthritis. Yes or no? So these are the basic indication of operations. That as I said, instability, posterior lip, how much involved, the stability test and stability and instability. Then also fragments lying there, fragments lying in between the two fragments, yes or no? So all these things are also to be considered, and these are the category of patients who need to go for operative treatment. As you know, in the operative treatment also, I would like to emphasize some other points also. That point is important. That as I said, that there is every possibility of associate fractures there. And associate fracture also determine about the future course of your treatment protocol. Who is going to what priority? Few examples I am going to give. 1. If there is a acetabulum fracture along with the femoral head fracture, probably this can be addressed in the same situation. Yes, you repair the head, you repair the acetabular posterior lip also. 1 point. But if there is a fracture neck femur in case of adult gets priority than that of your acetabular fractures. Here you need to fix there. That can be done in 2 stages or you can do 1 stage also. But preferably most of the surgeons used to do early fixation on the neck. But this is not applicable for trochanteric fracture. Trochanteric fracture one can wait, which is not the emergency one. Right? Now what about the flexor set femur? If the flexor set femur is there, then if you do a interlocking there and the incision is going in the posterior superior direction, probably this incision may come to play if you are going to take up the patient for leg and back exposure. Getting my point? So if this, you are planning that if this patient is having a posterior acetabular fractures, I need to go for your operative treatment sometime later, and you are doing the fixation of the femur, probably this incision may come with that incision overlapping. So that is not the ideal situation. Though flexor femur gets priority over the acetabular fracture, I need to fix it early, then acetabular next. Probably you may need to go for open induction here to do retrograde nailing technique or even plate fixation there. But do it first, then go for the acetabular fracture. Are you getting my point? But I am talking about the sequence of the importance that there is associate fracture is more common in case of acetabular fracture, particularly in case of young adult. Right? So there is pelvis fracture is there, pelvic gets the priority, then there are acetabular fractures. So these are the things you have to clarify. And the time of intervention, as I said, the time of intervention, early fixation is not desired. Many times probably these patients need to undergo stabilize. Optimization of the patient is important to take up a challenging task of operative treatment. Yes, so you need to stabilize the patient, you need to optimize the patient. That is almost take the 1 week time, and tremendous edema and other things are there. And that is why most of the surgeons, they prefer to do the operation in the secondary. One point, but few surgeons also prefer to do the fixation, particularly if it is involving only the posterior acetabulum. Posteriorly. If the posterior acetabulum is concerned, probably these are the candidates where one can do it with early fixation. Posteriorly. Big chunk of bone is coming out, dislocation is there, probably you can take it early. But as such, most of the surgeons, they prefer to go for the second week time because tremendous edema, tremendous bleeding, trauma. So that is why prefer to do in the second week of time. Earlier, ideal to go for it. So depending upon this, I have already told you about the various fractures. Now what approach? Whether you go anteriorly, whether you go posteriorly, whether you need to go combinedly, it entirely depends upon the elementary fracture and also associate fractures. Now, next point is to how to approach. Approach, necessarily you know there are two columns. So necessarily posterior column is involved, that is you have to go posteriorly. And in posterior column, posterior exposure, it is the leg and back technique. You know, that is the incision probably is most suitable for this. You know this thing. Then another thing is that leg and back. But ilioinguinal and iliofemoral, these are the another incision from the anterior side. And there is extensively extensile iliofemoral incision to make it more extensive sometimes to address both bicolumn. So I am talking about four things. Posterior, leg and back, iliofemoral, ilioinguinal, and one is combine. Combine is mostly done for both column. Now, what is the both column concept and the operation as concerned? Many times, if there is a minor fracture in the anterior, suppose I have already told you associate fractures already. I have already mentioned that the 5 elementary fracture, the posterior column, posterior lip, yes or no, anterior column, anterior lip, then tenebrous fracture. These are the 5. On the other hand, combination of the elementary fractures like the posterior column and posterior lip, 1. Tenebrous fracture extending down as a T, another. The anterior column along the anterior lip, yes. Then anterior column and bicolumnar fracture. These are the another associate fractures. Are you getting my point? These are the combination of fractures. Then most of the time, double elementary fractures are coming as associate fractures. The posterior column, posterior lip, anterior column, anterior lip, bicolumnar and T-shaped fractures. T-shaped, while a T is coming. Already, but as such, the tenebrous fractures are 3. As I told you, one is your infratactile, juxtatactile, and another is your transtactile, depending upon the articular surface where it is going through. Yes. Now you have to select from the configuration. You have to analyze that which approach is going to suitable first. And many times there are minor fractures which are lying anteriorly. If you do a fixation from the posterior side, many times you can liberate and do the reduction of the anterior column. But that is possible if the patient is taken up early. Mind it, again I am talking about. So sometimes if you are supposing the column is extending from anterior to posterior, probably your posterior reductions may help you to get a reduction in the anterior column in a fresh fracture. But if you take up the patient late, suppose in 2 weeks time, 3 weeks time, probably joint process is, union process is going on, at this juncture it may not be possible. So levering from the anterior side to posterior side to anterior side is possible to get a reduction, particularly in fresh fracture in first week time or first early second week. But if it is somehow you need to delay it, probably you need to be more difficult for reductions, and here the opportunity of getting this levering action for addressing the anterior part with the posterior exposure, with the anterior part may not be possible. There you may need to go for extensile exposure with data which is called extensile exposure to address the both the columns. Got my point? So I am talking about the various exposures here in this juncture, that which approach is going to help you and what at times you need to modify the incisions and if you are unable to address it. Yes, so that is your regarding the basic operation technique. That is conservative treatment, where to you can do with conservative treatment. One, operative treatment, what are the indication of the operative treatment, where to do operative treatment. If so, what is the suitable time to do the operation? Again, after optimizations, now what is the exposure? Whether I will go posteriorly, anteriorly, what are the posterior incision? I tell you, anteriorly what, and when you have to do a combine. And is there anything more? Yes, we do have. Sometimes we may need to go for your what? Anybody? TBL? Anybody? Osteotomy? Some osteotomy? Yeah, osteotomy of the trochanter osteotomy. You can track this trochanter above sleeve osteotomy, reflect it, the gluteus medius muscles particularly, to see this part. That is another additional thing one can do, sometimes necessary to do the exposures better. So these are the various exposure. Fixation part, pelvic flexor. Here most of the recon plates are mostly used, pelvic recon plates are mostly used. Screws mostly a 3.5 cortical screw are the choice. Initial reduction should to be done with the K-wire reduction, then stabilizations, then you go for the recon plate according to need. Sometimes you may go for your double plate, sometimes you get a single plate, sometimes springs plate also is there, which is going to help you in particularly while the medial blowout is there. So these are all in nutshell the line of approach of your treatment as far as the acetabulum fracture is concerned. Yes, we have discussed about the X-ray, different importance of the different views of the X-ray and the analysis of the X-rays. Treatment protocol according to ATLS, categorize some persons for the conservative treatment, select it, then go for the operative treatment where you need to go. In the operative treatment, what exposure with posterior, anterior, or sometimes even combined, and sometimes some extensive incision, sometimes even osteotomy also is important to have better exposure. So in nutshell, this is the line of complication. Other things we do not want to details everything, but I want to give you a very basic idea of this your approach of acetabulum. So far we have discussed about the anatomy, we have discussed the various mechanism of fracture, we have discussed the analysis of the fractures, we have discussed about the various columns. Yes or no? We have discussed about the X-ray, we have discussed about the CT scan's importance, and also categorize how to deal these situations with conservative or operative. Do you have anything to ask?